So I'm almost Dr. Sandstrom. I'm Dr. Rizell, and I will present data regarding hepatocellular carcinoma in Sweden. I'm very honored on behalf of the Swedish National Liver Registry to be able to present these data. And since 2008, we did have a Swedish National Registry. And for those unfamiliar with Sweden, we are surrounded by Norway, Finland, and are probably more famous for the scenery than for the inhabitants, because it's one of the most beautiful countries in the world, but very rural most of the country. The healthcare system is financed by taxes. The HCC is a rather rare disease with an incidence of 400, and now we have analyzed all patients from 2009 to 2003, that is 1,835 cases then. And comparing then men and women between the regions, we can see that there are more men getting HCCs. There are differences between the regions, mostly regarding men, and we also know that there are higher incidence of cirrhosis around the larger cities. Associated liver disease are seen around 70%, and the most common one is hepatitis C, which is also more common around the larger cities. During 2013, we also registered how many of those that were detected by surveillance, and we could see that 43% of those detected by surveillance could be treated with curative intent. So, once more then, if we look at tumor stage depending on underlying liver disease, we could then see that of those with underlying liver disease, we could see that twice as many were within Milan criteria, 38% versus 17%, and they had half the size of tumors with a median tumor size of 40 millimeter versus 80 millimeter. If we then look at outcome, we can see that gender, there were no difference between men and women for 5-year survival. The TNM system actually had prognostic information. So for T1 patients, that's single tumors irrespective of size without lymph node metastasis, we can see that the 3-year survival is 61%, for T2 patients 37%, and for T3 patients without lymph node metastasis 15%. So this discriminates very good. So in this graph we have gathered all the curatively aiming treatments. However, of course, these are not comparable regarding tumor burden and liver function. But we can see then that the 3-year survival for transplantation gives the best overall survival with 86% 3-year survival, liver resection 66%, and ablation. You can see that comparing to many other countries, we also do have rather large numbers or large proportion of patients that were transplanted. In the register, we also registered the aim from the multidisciplinary conference regarding best supportive care and palliative treatment, and we can see that those not scheduled for any treatments have very short survival. Sorafenib 7 months and chemoembolization 17 months. So in summary, we can see that comparing regions, there are trends, but there are no significant differences between the regions. There is a problem, we think that there are very huge variation between the first choice of treatment allocation between the regions. Since 2009, we finalized the first national guideline for HCC. In spite of that, we still see that there are very huge variation regarding what treatment do we offer the patients. However, as we then have said, so far we we cannot say that the regions still are separated. So in summary, the present national strategies from SWELIV and from the national guidelines perspective is that we would like to increase the survived population and the quality of screening. We want to standardize walking up and MDT, and in that perspective we think that Denmark has been a good example that we would like to equal. And furthermore, we planned to start a national downsizing protocol now also to increase the number of patients liver transplanted further. Thank you very much.